Patients that have headaches really need to seek out medical care when they're having headaches that are impeding or impairing their quality of life, when it's limiting their function at school or at work, or they can't go on vacation because they're so afraid they're going to have a disabling headache and ruin the vacation, not only for themselves, but for their family or friends that they may be going with. So how often that is, I can't really tell you. Some patients may say that I have only 1 or 2 headaches a month, and that doesn't sound like a lot. But if their headaches last for 3 or 4 days each, that means they're having 8 headache days a month. That's more than 25% of the month. They're down with a disabling headache. They're in bed. They're incapacitated. They're missing work, missing school, and again, missing vacation or family time. So if they're having, it depends on how many headache days a month. If you have an occasional mild headache, when I say occasional, I mean no more than 1 or 2 a month, and you can take a couple of over-the-counter medications, and it gets rid of your headache and it's over with, and you can keep on going and doing what you're doing, you don't really need to seek out professional care for your headaches or migraine problems, or cluster headaches for that matter. Those patients don't need to seek out care. But if you have 2 headaches a month and they're disabling, and you're in bed for 24 to 48 hours and you can't function, and you find that you're missing school, you're missing work, or you're not going on vacation because you're afraid that you're going to have a bad headache like that, those are the patients that need to come in and see me. Headache patients are very interesting because they never think that their headaches are serious enough to warrant medical attention. They're also afraid that they're going to be told that it's in their head, or that they're crazy, or that it's not, they're just making it up. That's actually not true. Headaches, and particularly migraine headache disorder, as well as cluster headache disorder, is a real organic medical problem that we understand a lot about. We understand that headache sufferers suffer from low levels of a brain neurotransmitter called serotonin. And so it's an organic problem that we know a lot about. This is an organic medical problem, just like diabetes or asthma or high blood pressure. And the important thing is to understand that we have excellent medications that do not involve the use of narcotics or painkillers. We have other excellent medications to help people control their headaches, to prevent the headaches from occurring, and also if they do happen to have a breakthrough migraine or cluster headache, we have excellent medications that will abort and stop a migraine or cluster headache from progressing. So instead of suffering for several hours to days with a headache, we have medications that can actually stop a migraine in as little as 5 to 10 minutes. And again, none of this involves using any narcotics or painkillers. In a general family practitioner's office or general internist's office, 1 out of 10 visits is for the complaint of headache. So that's 10% of all general practitioner's office visits is for the complaint of headache. And unfortunately, here in the United States, the standard treatment was to give them something like Furacet or Furanol or another mild narcotic medication to just stop the pain. A little bit more sophisticated family practitioner or internist might use one of the newer triptan drugs. Triptan drugs are drugs that are custom designed medications used to abort treatment or abort acute migraine headaches and also cluster headaches. Common drugs that people may have heard of are Imitrex, Maxalt, Axert, Zomig, Relpax. There are several of them. And there's also injectable form. Imitrex or sumatriptan comes in an injectable form as well. And those are brand name medications. Most of them are brand name. Sumatriptan was the first generic triptan available, and that's available both in pill and injectable form. It's the only triptan that is available in injectable form. And it's the injectable form of this medication that we can use, that I can use as a headache specialist to treat my patients that have an acute, severe, disabling migraine headache with or without nausea or vomiting. Some patients have such severe disabling migraines that they're vomiting, they can't function, and they're really, truly incapacitated, and they're disabled. It's the migraine, an acute severe migraine is the #1 cause of temporary total disability in the United States. Temporary total meaning anywhere from hours to, if your headache lasts for 2 or 3 days, you may be incapacitated for several days. With these new modern day, really miracle medications, the triptans, we can stop or abort that headache in as little as 5 to 10 minutes with the injectable. And we use that in combination. I use it in combination with an anti-nausea and vomiting drug so that I can restore that patient's functioning and get them back to work or school or family function in a few minutes. So they're not missing school, they're not missing work, because if you miss too much work, you could jeopardize your work status. And I have had patients that have lost their job because they haven't been seeing me to get their headaches under control. So it's a real serious socioeconomic problem that literally costs billions of dollars per year in both lost production, but also in treatment. So better treatment results in better results, better quality of life, and improved functioning. Well, the problem with headaches are there's such a wide and varied number of different types of headaches. Actually, the headache patients that I see, it's not uncommon for them to have anywhere from 2 to 4 different types of headaches. And in my patient population of seeing headache patients, that's the norm rather than the exception. It's an exception to have just an occasional tension headache, if you want to call it tension headache, or an occasional migraine headaches. I'm not really seeing those patients because, again, they can take some over-the-counter medications and they're often running no problem. The patients I'm seeing are having recurrent, disabling, incapacitating headaches on top of their other headache disorder. Like they may have chronic daily headaches. They have some degree of head pain every day, but they're not migraine. And then 2 to 4 or 5 times a month, they may have a migraine headache that can last anywhere from a few hours to a day or two. So these people are having a huge number of headaches. There's another type of headache disorder called occipital neuralgia, which is an inflammation at the base of the skull, which causes a different type of headache that can actually mimic migraines, but it does not respond to the triptans or other typical anti-headache medications because it's its own unique headache type, and it requires its own special treatment. And that's the important thing that we should understand, is that these 2 to 4 different types of headaches require different therapy. And the key is to diagnose all the different types of headaches that a patient may be suffering from, and then prescribe specific therapy to get rid of each one of those types of headache. And so if you have 4 different headache types, it requires 4 different types of therapy to globally treat all those headache types simultaneously to get the patient's headache disorder under control, so then again, we can improve their quality of life, and basically we need to stop their suffering. The reason we want to avoid using narcotics in the management of migraine headache or any other kind of headache disorder is, number 1, they don't work. I have patients tell me all the time they don't work. Number 2, narcotics are addictive and habit forming. People become accidental addicts because what they find themselves doing, particularly the patients with chronic daily headaches, find that they're suddenly taking hydrocodone, oxycodone, or even stronger painkillers to get their head pain under control, and they have to take more and more. Well, all of a sudden they find that they're habituated or addicted to these medications. They can't get off of them. They become accidental addicts. We want to avoid that because of the addiction potential, but also because narcotics don't really help treat the headache. They just mask the pain temporarily, and when the narcotics wear off, then the pain comes back. It's like, I use the analogy all the time with my patient, it's like taking paint and you're painting over rotted wood. The problem is there's still rotted wood underneath the paint. What we want to do is take out the rotted wood, put in new clean wood, and then if you want to, put a coat of paint on it. But don't use narcotics as your paint. That's the whole point. There are other excellent medications that we have, number 1, to prevent migraine and other headaches, including cluster headaches, from occurring in the first place. And when you do have a breakthrough, we have great abortive medications to stop the headache from progressing. We can stop the nausea and vomiting. And again, the whole point is to control the headaches, but if you do have a headache, get you back to your normal functioning as fast as possible. What I feel that patients should think about is that if they do have headaches, or if their spouse or their children, the incidence of headache in children is just as high as it is in adults. There's 30 to 50 million Americans affected with recurrent disabling headaches in the United States. You know, that's about 1/6 of the population. That's a huge number of people affected with recurrent disabling headache disorder. And so it's a major health problem in the United States. Again, the socioeconomic cost is in the billions of dollars per year in lost work and school and production. So it's a major health problem in the United States that's completely not well attended to. And that's why I think the patients that are having 2 or more headaches per month, or prolonged headaches or disabling headaches, cluster headaches may occur for 1 to 2 months a year, and then they'll be fine completely without any headache for a year or 2. But during that 2 months that they're having cluster headaches, which can occur anywhere from 1 to several times a day, they call cluster headaches suicide headaches for a good reason. The incidence of suicide in cluster headache sufferers is 3 times that of the general population, because the pain is so severe and so excruciating that these patients tell you they would rather be dead than suffer from another one of these headaches. And if someone tells you that, you can almost make the diagnosis of cluster headache just on them saying that alone. But what I'm conveying to patients is, if you do have a headache, don't think that you have to silently suffer with this. There's no reason for you to suffer. We have great treatment. This is not a psychiatric condition. It's an organic medical problem, and there's great treatment. But the key is to get in and see a headache subspecialist, neurologist, who knows about these different type of headache disorders and has the treatment that he or she can provide you with to get rid of all your headache types and to improve your quality of life, stop the suffering, and allow you just to be more productive.